Good afternoon, everyone. Happy Friday. Welcome to Ask the Experts #2 of the week.
I know, number 2 of the week and the first of the month. Happy November.
I know. I can't believe we're kicking off. So we're so excited to be back with you this week. And we're super excited to have our expert with us. If you have been following along in her story on social media, she has been doing a lot of education and connecting with communities about breast imaging and the importance throughout the entire month of October. So we are excited to have her with us today, Dr. Robyn Roth, for some breast imaging myth busting. So we'll cover lots of questions in the time that we have together.
Yeah, absolutely a legend. And she is able to really talk and address so many good conversation starters that a lot of us, if you're on Instagram, if you're on social media, boy, you can get lost in the noise. And she quiets that noise and really gives us the fact and the news. And that's why we are so happy to bring this segment to our community and really bust those myths that are out there.
Thank you for having me.
Yeah, we're so excited. So
Likewise.
before we hop in, Sue and I have some housekeeping. So for those of you that don't know us, my name is Erin Pellegrin. I'm our Senior Director of Education and Culinary Nutrition here at Unite for Her. You often see me partnered along with Sue for our education segments.
Yeah, and I'm Sue Weldon. I'm the founder and CEO of Unite for Her and 20-year survivor. I always like to put that in there. 20 years, Erin.
Yeah. I know.
Important.
I know. I'll tell you, we can't do what we do here with our education series without our presenting sponsors, and they are extraordinary. So we would love to give them a shout out. Thank you for all you do for Unite for Her and our community. Our presenting sponsors today are West, Merck, and Daiichi Sankyo, with additional support from Lilly, GSK, Gilead Sciences, Pfizer, Immunogen, which is now a part of AbbVie. We are most grateful. We do over 40 of these segments live. It is really key in our community that we are there for you, really talking about all the top of mind topics, and we wouldn't be able to do it without them. So thank you to our presenting and supporting sponsors.
Absolutely.
All right, welcome to Dr. Robyn Roth. So let me do a little bit of her bio. Obviously, we talked about her and her social media platform, but she's an Ivy League trained board certified radiologist specializing in breast and abdominal imaging, and a breast imaging fellowship doctor. She is better known as the Boobie Doc, her popular social media account where she discusses breast cancer and breast health in an educational and fun way. Dr. Roth hosts a podcast, The Girlfriend's Guide to Breast Cancer, Breast Health, and Beyond, to help navigate those with breast cancer diagnosis. And it's available on all of her podcast platforms. She is a writer, a speaker, educator, and breast cancer advocate. So please join me in welcoming our expert today, Dr. Robyn Roth, the Boobie Doc herself. Hi there, Robyn. How are you?
Hi, I'm great. Thanks so much for having me.
You got it. You have been such a catalyst and such a partner in the community. I just want to thank you. I know that Unite for Her has benefited directly from all of your advocacy. And obviously, we have this partnership with your patients. So we appreciate your time here and really getting your expertise today. So thank you for all you do.
I'm happy to do it. Thank you so much for having me.
Good. Okay, we are going to dive right in, right? And
let's do it.
There's a lot of myths out there, right? A lot of questions, a lot of myths. So let's start with some easy ones, right?
Yeah.
Most people who are diagnosed with breast cancer have a family history. Let's start with that one.
That's absolutely false. We know that most people, I think greater than 90% of people have no known family history or genetic mutation. So I think it's important, if you do have a family history, that is a very strong risk factor, especially if it's a first degree relative and premenopausal breast cancer. The age of diagnosis does matter. But if you don't have a family history, that is certainly not, we are all at risk for breast cancer. The two greatest risk factors for developing breast cancer are being female and getting older. So by definition, we are all at risk. And, majority of the young women that we're seeing in practice that are being diagnosed don't have the typical risk factors that we're looking for. So I think it's just really important for everyone to be their own breast advocate and be breast self-aware and stay up to date on screening recommendations, and also understand your own breast cancer risk factors. I think we're going to talk about that more. But I do like to encourage every woman, especially Ashkenazi Jewish and Black women, to have a formal breast cancer risk assessment before the age of 30, ideally at age 25. So we can identify those that are high risk that would benefit from earlier or supplemental screening with MRI. I think that's important
Perfect.
too.
Thank you. And
Mhm.
while you're saying that, as it's coming to my mind, if they do identify as a higher risk, is it then covered by insurance if they get their exams, Dr. Roth?
Yeah, it should be. So, when we run this risk calculator, I like to encourage people. It's always best done with your provider, but you can certainly run your own breast cancer risk score using something called the Tyrer-Cuzick calculator, Tyrer-Cuzick calculator. You can Google it. Average risk is about 12 to 13%. High risk is when you start seeing over 20%, and those are the people that we would want to start screening with MRI as early as age 25, and then start adding a mammogram on as early as age 30, and then kind of alternating. A good rule of thumb is like 10 years before a first degree relative that was diagnosed. So let's say your mom was diagnosed with breast cancer at age 35, you would start MRI at age 25, and then start mammograms at age 30.
Great. Thank you. Thank you for
Mm-hmm.
that. Back on that same subject, is only old women or men
Mm-hmm.
breast cancer?
Yeah, so I think there's a big misconception that breast cancer is an old person's disease. And unfortunately, the numbers are showing that we're seeing more and more younger people getting diagnosed with breast cancer, and the numbers are actually going down for older individuals. So the latest numbers, there was recently the American Cancer Society put out their 2024 facts and figures, and it showed from 2012 to 2021 that breast cancer was rising across all women by 1% per year. But that number was higher in young women under the age of 50. That was increasing at 1.6% per year. And perhaps the most startling increase was in the 20-year-old women. We were seeing a rise of 2.2% per year. So there's definitely something going on, environmentally, what we're putting in our body. I think a lot of it has to do with lifestyle factors such as, being overweight, physical inactivity, alcohol, and, increased access to vaping and things like that. But there's not one thing that's causing this rise. And until we know exactly what's causing it, we just have to be really breast self-aware. Like I said, a lot of these younger women are not being screened with imaging. So, which is why it's so important, to do a monthly self breast exam. I like to encourage people to do feel it on the first. So that's why we have to, if you find something, we just have to, bring it to the attention of your doctor. And most likely it's not going to be anything serious, but it's really important to exclude breast cancer because we know it's on the rise.
Yeah. Yeah. It's so important too that you do understand, nutritional needs, sleep needs, stress needs, like all of those things. It's not one magic bullet, right? And
yeah, exactly.
if you can be aware of your surroundings and your lifestyle, it just gives you a little bit of a leg up, right? I mean, there's no clear answer there, but at least we can do what we can do.
Absolutely. I mean, I like to mention about 5 lifestyle changes that can lower your risk, but certainly they are not preventative. You could do everything right and still develop breast cancer, unfortunately. But maintaining a healthy weight, exercising at least 30 minutes a day, minimizing alcohol to less than 3 drinks per week, eating a diet that's rich in vegetables and fiber, and minimizing processed foods, and also maintaining normal vitamin D levels is actually lowers your risk as well. But like I said, it's one part of the piece of the puzzle, but and certainly we see plenty of people that do everything right and still unfortunately develop breast cancer. So there are certainly things that are out of our control as well.
Yeah, for sure. For sure.
Yeah.
How about this one? So Dr. Roth, mammograms cause breast cancer.
Yeah, this one is the most infuriating thing that I see on social media. So, mammograms have a very small dose of radiation. It's about 0.3 millisievert, which is equivalent to about flying cross country on a plane, or 7 weeks of background radiation. Just from the atmosphere, we get background radiation. So it is a very minimal dose of radiation, but the benefits far outweigh the risk. This is what the National Cancer Institute and multiple medical societies, this is why they still recommend mammograms. Mammograms are the only imaging modality that have shown to reduce mortality by up to 40% over the last few decades. It's really the gold standard at the moment. I'm sure that will be changing over time. We know that mammography is not perfect, especially if you have dense breast tissue, which we're going to talk about. Which is why I do recommend that women who have dense breast tissue consider adding an ultrasound or MRI depending on their risk factors. But certainly the radiation dose, early detection is the best protection. Finding cancer we want to find cancer at the earliest, most treatable stage, which gives you the best outcome and best chance of survival. So that's why, annual mammography beginning at age 40 in average risk individuals really saves the most lives.
Yeah, and that's why we're really glad that you are using your social media platform to really try and break those myths, right? And give the news,
Yeah.
the facts. Also, there's, a question, can mammograms smash tumors, causing them to explode and to break up and then spread the cancer if it's already present?
I've seen that on social media, and I don't know where that's coming from. Like, if that was the case, especially like even those two facts, like if mammograms cause cancer and, the squishing the mammograms cause cancer to spread, we would see more cancers in older women who've had multiple mammograms of their life. And we're seeing it in younger people who've never had a mammogram. This is not because of a mammogram causing, tumors to squish. And I don't know where that's coming from, but that is a really big misconception on social media.
Yeah, well, these are coming from our audience, and they're
Yeah.
hearing it on social media, right?
Listen, I hear all of it too. And it's really, it's like, it's a full-time job to bust these myths. The people that are trying to tell you that mammograms cause cancer and that, the compression is what spread the breast cancer, they're trying to sell you another type of imaging modality that is not approved for breast cancer screening. I've seen thermography. A big one that I've seen recently is QT imaging, which is a type of ultrasound. These really have no role at the moment in breast cancer screening. There's no long-term data. There's no studies that show that it can detect DCIS or ductal carcinoma in situ, which is the earliest form of cancer. That's why we do a mammogram. Like, mammograms are the only imaging modality that I know of as a breast radiologist that can detect the microcalcifications that can be associated with DCIS, which, if left untreated, would turn in most cases to invasive cancer. So that's why it's so important.
Yeah, thank you, Dr. Roth.
Mm-hmm.
Does breast cancer usually present as a lump?
Yeah, so most breast cancers do not present as a lump. By the time it presents as a lump, it's usually on the larger side. The goal of screening mammography and breast cancer screening is to detect breast cancers before they're palpable. So, we're trying to find those 1 millimeter tumors that are very treatable, like 1 centimeter tumors that are very treatable. Once you start feeling it, it's usually on the order of like 2 to 2.5 centimeters. So then it's on a good day. And then we're really talking about different stages then. So we really want to catch breast cancer at the earliest, most treatable stage. And that's why, they can present as a lump, certainly, especially if you're not being screened for breast cancer, if you're under the age of, 40. So it is important to take lumps seriously, but just know that most breast cancers do not present as lumps. And
Right.
lumps can also be many things. It could be a cyst, it could be a fibroadenoma. There are certainly lots of benign masses that can be explained with a lump. But, we do take it seriously, but thankfully most don't present as a lump.
Yeah. And then I think for people who have had mastectomy, would a mammogram actually show a reoccurrence on the chest wall?
So no, and the reason is because when they do the mastectomy and they place the implant, all the breast tissue is usually pretty superficial to the implant. So that's why there's really not a role for mammograms after you've had a mastectomy. If you know that it's hard to know how much breast tissue is left. I mean, I think it is a good question to ask your breast surgeon, like how much breast tissue is left, because every so often when I'm reading an MRI on a patient that had a mastectomy, I see a decent amount of breast tissue.
Yeah.
So mastectomy lowers your risk by, they say like 90%, but it's not zero. And the more breast tissue that's left, the more your risk. The breast cancers that do present in women that have had a mastectomy is usually felt on palpation because it's pretty superficial, especially if you've had some reconstruction. The chest wall recurrences are tough because they happen below the implant.
Yes.
So that's not image on a mammogram. That's image on an MRI if we're lucky, if it's seen. They can be tricky. Sometimes they present as a chest finding, like on a CT scan, but those are the tricky ones that are hard to detect, unfortunately.
Okay, and that's your screening choice would be an MRI or a CT scan.
Yeah, well, CT scan's really usually done for something else. Let's say they're having chest pain because it's a,
Okay.
you know, maybe it's a rib pain.
Yeah.
Then they might get the CT. CT really doesn't have a role for breast cancer screening. But if you've had a mastectomy and you are still at a high risk, MRI, I don't know when they order MRIs. Usually, like I said, it's usually like physical exam and ultrasound if they find something. MRI would be if you still have a high risk or if you still have your other breast, and then we catch it on that one. I don't know who's ordering MRIs for someone who's had a mastectomy. Usually not, but it's a
Okay.
good question. Yeah.
Yeah. I know it's interesting because, the data on reoccurrence as well, I mean, it can be high, right? That data.
It can be higher.
So if
And
you have a mastectomy, is that lowering your risk of reoccurrence substantially?
it is, but and also it depends on the type of tumor. Like if you had a tumor that was originally close to the chest wall, or involved the chest wall, then they might have a greater like indication for doing an MRI, for screening. If we know that already you're at high risk to have a recurrence where you had it, then it might not be palpated on an exam because it was deep to begin with.
Right, right.
So these are all the things that kind of go into play when it's usually the surgeon or your breast cancer team that's deciding what to screen you with. But it is a good question, and it is something that you could ask your team if it's warranted in your case.
Yeah. All right. Here's another one for you.
Okay.
Deodorant causes breast cancer.
No, deodorant does not cause breast cancer. I use regular deodorant. Like I said, bras, deodorant, those are not proven to cause breast cancer. Um, I think people have a problem with the aluminum. If you really want to cut down your risk, like, I don't know, like heavy metals, I think there might be some theoretical risk, but there's no proven risk. And like I said, I think that there are breast cancer risks everywhere. So you have to live your life at some point. You can't just live in fear from everything, unfortunately. So I just, I cut where I can. And for me, I just use regular deodorant.
Yeah. There's other things that come into play too. And of course, all on social media, so many cleanses. So you
Yeah.
avoid breast cancer by doing a parasite cleanse and eating a green.
That really to me, those type of, I think it preys on people's fears of developing breast
Yeah,
cancer. And
right?
it's really dangerous. I think it's a slippery slope, especially when you see doctors promoting, um, these parasite cleanses or join this diet, and, you can prevent breast cancer. Like, says who? Like, is there a money back guarantee? Because there's nothing that I know of. Even even mastectomy is the greatest lower chance of lower your risk, but it's not zero, unfortunately.
Yeah. Yeah. Okay. Can you tell me, so there is information about breast cancers all being the same?
Yeah.
Yeah.
So breast cancer is one term to describe thousands of diseases, unfortunately, which is why I think a cure is so hard, because it's not just like one thing that we're trying to cure. Um, Breast cancer is very dependent on the type of breast cancer it is. Is it invasive ductal? Is it invasive lobular? Is it mixed? Is it DCIS? And then what type of hormone receptors it has, and then is it receptive to estrogen or progesterone? Does it have HER2 receptors? What's the Ki-67? Like, there are a number of things that really distinguish the breast cancers apart. So that's why it's not a one size fits all approach, and which is why I encourage people, like, if they do get diagnosed with breast cancer, be wary on social media and boards and all these things, because you can't compare your breast cancer to someone else's breast cancer unless you know specifically all those factors. So it can be really tricky to I think that you just have to listen to your healthcare team, get second opinions if you think something doesn't feel right for you, and ask the questions. But it is not one disease, it's really like thousands of diseases. And I think that you start to see more of an individualized approach, and we're only going to see more of that
Yes.
as we go
Say that, Dr.
further.
Roth.
Yeah.
Yeah, because
Yeah.
precision medicine and our targeted treatments, and
Yeah.
I mean, that was not around when I was diagnosed 20 years ago.
Yeah,
And
exactly.
it's come
But
so
we have
far.
so much more knowledge. It's come so far, and we've got so much
Yeah.
more to go, but it's getting there.
Yes, yes, for sure, for sure.
Yeah.
Can you talk a little bit about breast density? Because we do have a lot of questions about that and just their
Yeah.
history and DCIS and really
Yeah.
understanding what they can do even for their daughters,
Yeah.
about breast density.
So breast density is an important topic that we're just starting to talk about because it wasn't really even known until 2015. So breast density, when your breasts are composed of fat and fibroglandular tissue. So basically everything else. It's the ducts, it's the lobules, it's the fibroglandular tissue. That's the dense tissue is really where most of the breast cancers are happening. So when a radiologist, the only way to really truly know your breast density is by reading your mammogram report. A radiologist will assign your breasts one of four categories depending on how dense they are. So fatty and scattered are considered not dense, and then heterogeneously and extremely dense means that they are dense. And that means that you have greater than 50% fibroglandular tissue relative to fat. Dense breast tissue is not abnormal. It's very common. About 50% of women have dense breast tissue. The problem with dense breast tissue is it increases your risk of developing breast cancer. It also, by the more dense, the greater the risk. It also makes it harder to find breast cancers on a mammogram alone. So dense breast tissue is white, and breast cancers usually appear white on a mammogram. So think of it like finding a snowflake in a blizzard. The more snow you have, the harder it is to find a single snowflake. And the same can be said for dense breast tissue. So, because of that, I think it's like a double-edged sword. Dense breast tissue makes it harder to see a breast cancer on a mammogram alone, and also increases your risk. So, it is calculated in the breast cancer risk calculators now. So, and most of breast density is genetic. It's inherited. Your breast density can change over time when you have weight loss or weight gain, or you take any hormones. Things like that. Pregnancy can make your breasts appear more dense, but for the most part, it's genetic. So if your mom had dense breast tissue, you might be more likely to have dense breast tissue. So I always encourage women that have dense breast tissue to consider adding an ultrasound or MRI, depending on the risk factors. We typically reserve MRIs for greater than 20%, but that's not the case because there are abbreviated MRIs. There's more MRIs available now for people that don't have a high risk, that want that extra level of protection. But, by adding an ultrasound or MRI to your mammogram, if you have dense breast tissue, it allows us to find smaller breast cancers at a more treatable stage, potentially. So, it is something to consider, especially if you're a proactive patient. I am intermediate risk. I get an ultrasound in addition to my mammogram each year. So I think it's something that we all need to be aware of. And now, as of September 10th, you will get a notification in the mail after you get a mammogram saying whether your breasts are dense or not dense.
Yeah.
And with all the things I talked about.
Just to be able to explain what that is, like I keep saying,
Yeah.
Roth, they need to teach this when they teach about puberty in school, right? Like
I know. I think
young
that
girls
breast health.
know, right? Like
Yeah.
know what that means.
We're teaching breast health way too late. I think it's a taboo
Yeah,
topic for some reason. And I think
should not be.
part of my platform is about destigmatizing just breasts in general. Let's get
Yeah.
comfortable talking about them. There's no shame involved with breasts.
Yeah, and I think the subject, if it's, when the girls are younger, we have a big event, as the Pink Invitational, they're all young girls, ages, 8 to 18. And just to be able to have these conversations with them and their mothers and make it normalize it,
Mm-hmm.
right? And partner with, Love Your Lemons, and they can look at their
Yeah.
mothers differently and just start normalizing so they are familiar with their breast and they know the term,
Yeah.
right?
I got to tell you, I'm in the process, this is a tip, but I'm in the process of publishing a children's book, kind of destigmatizing this. So this is something I'm very passionate about.
Good, good. Thank you for that. With
Yeah.
that being said, are there certain new ACS guidelines about breast self-exams?
Yeah. So I disagree with the American Cancer Society very strongly on this recommendation. But as of, I think, over a decade now, the American Cancer Society does not recommend the self-breast exam because they said that, most young people are going to find false positives and it causes more stress and anxiety. But I have to strongly disagree with that because I think, but they recommend that women are breast self-aware. But if you're not doing it, you're not teaching the breast exam, you're not,
Self-aware.
you're not self-aware, then how could you find a change? And like I said, we're seeing this rise in young breast cancer, and the majority of these women are not being screened with mammography. So how else are they supposed to detect their breast cancers? I think that we really have to take know I say, know your body best, advocate for yourself. If you feel something, say something.
Great.
And, don't be afraid to ask your doctor. Like I always have this conversation. If like, let's say that they say it's just a clogged duct or it's just a cyst. Well, how do you know that? Is there any imaging test that we can do to exclude something more serious like breast cancer? Because most likely it is, but I've seen a number of women come in being, finally they get to my office to get the ultrasound and it's a cancer. And they're like, but my doctor told me it was just a clogged duct. And I think we just have to take our patients' complaints seriously. I think there's a lot of medical gaslighting going on, especially with young women's breasts. Because most likely it is just a clogged duct, but there is this rise that we are seeing that we have to take seriously.
Yeah, and be seen and heard. I mean, that is
Yeah,
at Unite for Her. We always talk about use your voice, use your voice.
yeah,
Make sure that if it does not feel good to you, you're
yeah,
the one that matters. So ask the
yeah,
question again, or ask it a different way, or go for another opinion until you
yeah.
get that peace of mind, right? And
Absolutely. Get that second opinion, because if your doctor is not taking your breast health seriously, then like there's probably other things that they're not listening to you on as well. So
yeah,
find a doctor that really listens to your complaints, and
agree.
it's a team approach. I think healthcare is.
Yeah,
Yeah.
yeah. Okay, if we could get like a little bit into the differences, the advantages, the disadvantages of regular mammogram with
Hmm.
contrast, breast MRI, ultrasound.
Mm.
You've actually touched on a lot of these things.
Yeah. So mammogram. So now we're pretty much. I think 3D mammography or tomosynthesis is pretty much the gold standard for breast cancer screening. Um, it it's kind of like the X-ray is taken in an arc, so it minimizes overlapping breast tissue, which a lot of things that we see on mammograms are due to overlapping breast tissue. So it's helped us lower our recall rate, our false positive recall rate, and improved cancer detection. Now, one of my favorite things is contrast mammography, and unfortunately, it's not used in the screening setting just yet. It's pretty much used in the diagnostic setting. I personally am a big fan of contrast mammography. We've been using it at Cooper since 2011. I think that we are going to see more of a role for contrast mammography in that intermediate dense breast tissue population that doesn't meet the criteria for MRI, but it does. It makes it harder to see, like we said. Contrast mammography is like a mammogram and an MRI had a baby. It's really helpful in making dense breast tissue kind of completely disappear on a mammogram, and anything that's enhancing is abnormal. So I think it's a really valuable tool that we're going to see more of. I think we're still trying to figure out where it fits in the screening population. It does need an IV in contrast. So it's one of those things that would be hard to do. Like I would love to do one on everybody, but I don't think we're going to get there because of the IV and the contrast. But it is a great tool, and I'm curious to see how it's going to play out over the next few years. Ultrasound is a great imaging modality. It has no radiation, it has no compression. It can't detect the microcalcifications that we're looking for in DCIS. And so it uses sound waves to make the pictures. It's a great supplement. It's a great addition to your mammogram. If you have dense breast tissue, it allows us to see the breast through the breast tissue better. MRI is another great imaging modality. It's magnetic resonance imaging. It is it's pretty much the most sensitive and specific imaging test that we can do. It's expensive, and the reason that it's so expensive is that it takes 45 minutes to complete. It requires IV gadolinium, but it allows us to see things really well. So we kind of usually reserve that for women that are high risk for breast cancer or have dense breast tissue and high risk. There's a few indications why we do an MRI, but that would always be in addition to your mammogram. Again, it cannot detect some of the early forms of DCIS that they were looking for as well.
Dr. Roth, I never heard of the mammogram with contrast. So are you
Yeah.
about the same contrast that's in an MRI?
No, it's actually the same contrast. So the contrast we use in contrast mammography is IV IsoView, or the other one is gadolinium based.
That's
Gadolinium based,
I know. Right.
has a little bit more of a side effect. Like if you have kidney failure, you wouldn't want to get gadolinium, because we know that it can kind of deposit in the kidneys and the brain. So we're wary to do it on everybody, but the contrast from a contrast mammogram is similar to the contrast you get in a CT scan. It's iodine-based contrast as opposed to gadolinium.
Okay. Okay, thank you for that. I
Yeah,
never
the
heard.
gadolinium is a heavy metal, which is again
Yeah,
why
I have
it's
heard of that. So I was starting to
yeah,
get concerned. I'm like, oh gosh, I heard that that was really, really
yeah.
on the
It
body. And
can be. It can,
Mhm.
gadolinium really doesn't cause problems if you have normal kidney function for the most part.
Okay.
Which is why we always have to check your kidney function before we give you gadolinium. We do the same for contrast, the iodinated contrast as well, but certainly for the gadolinium has more risk.
Yeah. So this is one, it comes with a lot of anxieties, right? When you are getting your mammograms, and especially if you have false positives. And this
Yeah,
question was just asking, is there any way to avoid the false positives that result in that mental and physical stress and undergoing a
yeah.
biopsy? It's tough, right?
It is tough. So false positive means we call you back from a mammogram and there ends up being not cancer there. Like I said, a lot of the things that we see on mammogram are due to overlapping tissue. So 3D mammograms help. Also, if you add an ultrasound onto your mammogram, if you have dense breast tissue, that will also kind of help us feel more confident with a negative study. And certainly like going every year will help us minimize our callback rate because we're basing our findings on comparison. So if you have, always bring your comparisons if you have, because a lot of times what we might see may just be your pattern of breast density. So it's always important. Comparisons are very much our friends. So, if you bring in your comparisons and come every year, then I think you're less likely to get those callbacks, or you should be, or asking, I think another thing is I suggest, maybe asking the radiologist if they would read your screening mammogram the same day if you don't mind waiting. I always read it if a patient asks. I think that the mental anguish of getting the letter in the mail like a week or two
Yeah.
later is really hard. So if you just find a place that would be willing to read your mammogram the same day, so if you need more images, they can get you scheduled, maybe not at that same day, but maybe another day, then that might help too. Um, with false positive biopsies, so that's another thing. So a lot of times we'll see a mass and we can't tell if it's cancer or not, and that's why we have to recommend a biopsy. And you're typically supposed to recommend biopsies for anything that's over a 2% chance of cancer. So the risk of it being cancer when we recommend a biopsy is anywhere between 2 to 95%. So it's very wide. You could, potentially ask the radiologist, like, how suspicious on that scale are you? Because sometimes I'll just say, this is unfortunately it looks like breast cancer, versus I think it's just a complicated cyst. I want to make it go away. So I think it's a conversation, when you go in for a diagnostic imaging you meet with a radiologist and you should meet with a radiologist and hopefully be able to have that discussion of like, how suspicious are you? Because I
Yes,
think that somewhere in that middle, you don't know where we stand unless you kind of push a little bit.
a little bit.
So, and I think
Your
you're
voice,
right
right?
to
Use your
right,
voice.
use your voice. Yeah.
Yeah, Dr. Roth, I didn't know that I could ask you to read my.
Yeah.
I
My
didn't.
radiologist friends are going to hate me right now, but I'm
Oh,
sorry. But like usually I think it's
but
reasonable to
that
ask.
would relieve that stress
Yeah.
and anxiety.
Or
Of
or
course.
if you could say, can they read it today? And someone call me to,
Yes,
to let me
yes.
know. I do that all the time. And I think most radiologists would be willing to
Okay.
do that.
Okay.
They should. Yeah.
Yeah. Okay, so then there's one that was just saying, that they trust mammograms. I know that we've talked about this and others
Mhm.
don't, and they have theirs annually. Do I need to do anything else on checking for breast cancer? And we've touched on a couple different things, but besides
Yeah.
the mammogram, because is there a stat out there, Dr. Roth, on how many mammograms are actually false positives? Do you know that stat?
Well, I think you're more interested in the false negatives, like where we read it as normal and it's really cancer there. And, the false negative on a mammogram, if you have dense breast tissue, can be up to like 50 to 75%. That's where, adding the supplemental imaging, such as ultrasound or MRI, depending on your risk factors, really comes into play. Because once we have a negative mammogram and ultrasound, then we feel a lot more confident if you have dense breast tissue. And also, I do think that there is a role for the monthly self breast exam, even if you're getting mammograms, because we know mammography is not perfect. We also know that there's interval cancers, like cancers pop up. There was truly nothing there. And then 6 months later, there's something there. And it's not that it may not have been that they missed it. Like some that has to start somewhere. So if you come on a day when it just like has a few cells and there's nothing there, and then, if you waited another year, it might be an aggressive type that kind of grows fast. Like we said, there's lots of different types. Younger women are more likely to have these aggressive subtypes that truly do pop up out of nowhere. So all these things, having a mammogram annually is important. Having supplemental imaging, if you have dense breast tissue, such as ultrasound or MRI, is important. If you're high risk, we tend to alternate them like every 6 months. So you're never going more than 6 months without a scan. So let's say you have a mammogram in January, then in July, you'll have your MRI. And then, so you're never going more than 6 months. So we're trying to catch those cancers that can pop up in between. And then on top of that, getting breast self-aware. And if you feel something, say something, and then it would be evaluated with the diagnostic imaging. If you're with diagnostic imaging, which would look like an ultrasound if you're under the age of 30, and then a mammogram and an ultrasound if you're age 30 and above. And in a diagnostic exam is different than a screening exam. A screening exam means you're asymptomatic, you're just coming in for your annual screening mammogram. Diagnostic means that for a screening mammogram, you come in, you get your test, and you leave, and you get the results a few days later. Diagnostic imaging is very different. We would do extra imaging tests, like we might order some extra views. We would certainly, if it was palpable, we want to do it under ultrasound. And then you meet with the radiologist who will then go over the results with you. So we definitely pay more attention to something if you have a complaint in that area, which is why it's always so important to let the technologist, let your doctor know so they can order the right test.
I know you talked about just even knowing your risk and understanding the tests that you can do. If you do have an elevated risk of over 20, was the count I think you gave, are the doctors and the insurance companies paying attention to that and allowing you to get these additional diagnostic imaging?
They should be. They really should be. I think that's something that you could fight if you have, documentation that you are high risk, or, if you go to a breast surgeon's office, they'll be able to kind of help you with that. But you should be approved for high risk screening if you are over 20%.
Okay. Okay. I think we covered everything. Is there anything you would like to leave our audience with, Dr. Roth?
I just think that we all have to, know our body, use your voice and advocate for yourself, ask questions, and then really stay up to date on your breast cancer screening. And, there's conflicting recommendations out there, and that's what's really confusing for people.
Yes.
So annual mammography beginning at age 40, an average risk individual stays in those lives, period, end. The USPTF recommends every 2 years, because they said that there's too much anxiety associated with it. But I don't think that's the choice of of a society to place their values on breast cancer screening. I think that women should be offered the most life-saving information and make the decision whether they want to come every year or 2 years. We don't place the same kind of feelings and anxiety and false positives on male prostate cancer screening. Why would we do it for breast cancer screening? So there was a really good article back in the day when they came out with this. They used to say 50, and then they came back on that. They said we were wrong. It's not 50. Yes. I think we're going to see the same thing.
When that happens, so much confusion.
There was this article. It's don't you worry your pretty little head about breast cancer. We're big girls. We could handle the information. And then there's also this recommendation of by them stopping at age 75, which is completely ridiculous, because we know our breast cancer risk goes up as you get older. 75 is the new 45. We are living longer and longer. The American College of Radiology says continue as your life expectancy is 5 to 10 years. You're willing to undergo additional testing and biopsies if it was, could be breast cancer. There are certainly some 49-year-olds that are in terrible health that maybe we shouldn't be doing mammograms on. They've got bigger problems. I think that you really have to look at the patient, but I think 75 is way too young to stop screening.
Yeah. And you're your best advocate. You know your body, you know your risk factor, and if you don't know it, we can give you tools to get there.
Absolutely.
I think about what you were saying. I mean, if 50% of the population has dense breast, and then you're going every other year.
Yeah.
That doesn't make sense,
It
right?
doesn't make sense. We saw in the COVID pandemic what happened when women were missing their annual mammograms. They were getting diagnosed with more late stage breast cancers. And, it's more than just the mortality rate. It's also like the complications that come with breast cancer treatment. Like that is not for free either. You know very well that, radiation, chemotherapy, all these things have side effects that, so if we can avoid chemotherapy by catching it early, then you're just in a better shape. Like you don't have the chemo brain, you don't have the complications the long-term complications from chemotherapy that you might get. So we have to look at this too, because, breast cancer is very treatable, which means that you're going to live a long, happy, healthy life after this. So we want to catch it as early so we can make your life as good as it can be after you beat breast cancer and living as a survivor.
Yeah. Well, thank you, Dr. Roth. I appreciate you. I appreciate you having a platform on a social media platform that can be really confusing and really dangerous at times, right? So
yes, absolutely.
keep doing what you're doing. We appreciate you so much.
Thank you.
As well.
And please follow me at the Boobie Docs, like across all social media platforms. Yeah, I'm most active on Instagram. And I know that a lot of people were asking kind of more specific questions. I'm happy to answer more of that on social media. I offer a weekly Q&A for my subscribers. So if there's something that you like really want to talk about, I'm happy to talk about that with you on Instagram, on social media. So don't hesitate to reach out.
Dr. Roth, because we did have some very specific ones, and it really needs to be one-on-one with you so that you can get more information, right? You don't want to give anything that's not fully, vetted. So thank you so much. We appreciate
You're welcome.
you. Have a good
Pleasure.
day.
You too. Thank you so much.
You got it.
Bye.
All right. Bye.
Bye.
All right. Well, that was a wonderful Ask the Experts. Knowledge is power. I do love it when our community ends up talking about how to use their voice and making sure that they advocate for themselves and putting yourself out there. It's okay if you disagree with what your doctor's saying until you feel comfortable. That is the most important tool you have. And we want to self-advocate. We want to be proactive. It's not one magic bullet, just like Dr. Roth said, right? There's a variety of different factors. And at Unite for Her, we always talk about what we can do, right? Not so much what we can't do, what we can do. So Erin, thank you so much for bringing Dr. Roth in. We appreciate that. And you want to give us a little shout out for our next virtual hangout coming out?
Absolutely. So this is just the start of a very active, very exciting November. So please join us next Wednesday for our virtual hangout. So that is Wednesday, November 6th, 5 p.m. Eastern time. We will be joined by occupational therapists and certified sexual therapist, Dr. Catherine Ellis. So we are giving attendees and those that are watching the confidence, the tools to have what can be an uncomfortable conversation, but we know it is so important. So please join us. You can register for our Zoom event online at uniteforher.org. But if you can't make it, it is recorded and it will be in our virtual library. So please stay tuned to all of our social media. We've got so much happening throughout November, as well as fundraisers that we are looking forward to next week as well. So definitely continue with us for this exciting journey.
Yeah, and if anybody wants to join us for our chef event, 25 chefs over in Phoenixville Foundry. It is extraordinary. It's a fun one. Get your cocktail dress ready. It's always a good one. Yeah.
Always.
Yeah. Well, that library, Erin, I'm glad you mentioned it. I know that Rachel will put that in the chat. That library is such a resource. It's trusted, it's vetted. We have our advisors on there, just topic after topic after topic. So it's worth a look. So please get in there, take a look at the different areas, virtual hangouts, speaker series, Ask the Experts for all different types of topics, including the one that we're talking about next week. All right, Erin, another shout out to our sponsors, please.
Oh, absolutely. We couldn't do this without them. So we are so grateful to our digital education sponsors. So today's Ask the Experts is presented by West, Merck, and Daiichi Sankyo. And we have additional support from Lilly, GSK, Gilead Sciences, Pfizer, and Immunogen, now part of AbbVie. So we are so grateful for their ongoing support of all of this information we are bringing to you.
All right. That's another Ask the Experts in the book.
I love it. I love it.
Thank you for being here, Erin. Thank you, everybody.
Thank you.
Have a wonderful
Take care,
weekend.
everyone.
Bye-bye.